Hey everyone, thank you for being with us tonight. So I'm Dr. Raslan and I'm happy to talk with you today about rheumatoid arthritis. Let me start here by sharing my screen. Okay, so today our topic will be about rheumatoid arthritis. I'm going to do a brief talk about rheumatoid arthritis, try to define it and talk about what do we have new in its management. And then I'm happy to take any questions after that. So rheumatology, many of you know, maybe the rheumatology is the branch of medicine that usually manages rheumatic diseases, which are autoimmune and inflammatory disorders that most of the time involve the musculoskeletal system, like the joints and the muscles, but every organ could be involved with autoimmune disease. Actually, the word rheuma is a Greek word. It means flow. And it's because the Greek physicians, the early Greek physicians noticed that these diseases tend to flow through the body, like they move between different joints, they affect different organs. And this is where the word comes from, rheumatology. So it's originally a Greek word. These are some of the rheumatic diseases that we manage. So you see the first two, osteoarthritis and gout and pseudogout, these are not autoimmune diseases, but these are actually some of the most common arthritic conditions. They're caused by other processes other than autoimmune inflammation. Everything else you see, rheumatoid arthritis and the others are examples of some of the autoimmune diseases that we manage in rheumatology. To talk about autoimmune diseases, we need to understand what's the immune system. The immune system is a very complex network of different cells and tissues and organs that is, its main function is to defend the body against anything harmful. You can imagine it as like a big army that's basically working together. It has many units and each of them has its own function in defending the body, and it works in different parts of the body. The main weapon that the immune system uses is inflammation. And that's why when the immune system, let's say you get a cut on your forearm, you get swelling there and you get redness. And this is because the immune system, when you have the cut there, rushes to the area to basically prevent any bacteria, let's say, from coming through to the bloodstream. And it does that through causing inflammation in the area. So inflammation is a weapon that the immune system uses to remove anything harmful from the body, and even to prevent cancer or to prevent the spread of cancer. Now, in the case of an autoimmune disease, as it's exactly as it sounds, the immune system is actually targeting the body with the inflammation by mistake, and this leads usually to inflammation in the organ that's being targeted, whether it's the joints, the muscles, or other organs. This is like a simplification of the immune system. You see, these are the different immune cells that we have, and there are many, many of them. They have different functions throughout the body and in different parts of the immune system. And before I talk about rheumatoid arthritis, our main topic, I want to talk about osteoarthritis because it's the most common kind of arthritis. So when you hear that someone has arthritis, it usually means osteoarthritis. You know, if someone says, I have arthritis, or my grandma had arthritis, most of the time, this is osteoarthritis because this is the most common form of arthritis. And so osteoarthritis is what we describe it as the wear and tear in the joints. It is almost everyone of us at some point will have osteoarthritis. It affects mostly the hands, the spine, the shoulders, the knees, the hips. And osteoarthritis, we call it wear and tear. It's more complex than that. It has more, different mechanisms that are involved in it, including genetics, including lifestyle and injuries. But in general, what happens that if you look here at the normal joint, so with a normal joint, you see you have the two bones that are forming the joint. You have a healthy cartilage between the bones. And this cartilage produces what we call the joint fluid or the synovial fluid, which is a normal fluid that's supposed to be there. And you have the capsule of the joint and the tendons around the joint that keep it stable. So this structure here is normal. This cartilage and fluid provides the flexibility and what we call the cushion to the joint to protect it when it moves. So it's not painful, so it is flexible. What happens with osteoarthritis is that over time, this cartilage here wears off. Now, when the cartilage wears off, the cartilage is what usually produces the fluid. So you have less and less fluids in the joint. So you have less cartilage and you have less fluid. The bones become exposed and they become closer to each other. So with movement, they can come in contact with each other. And this is what we call usually bone on bone, just because the bones are coming in contact with each other. So this contact is painful because the bones have a lot of nerve and also causes irritation in the bones, which causes changes in the form of the joint, some deformities in the joint, some stiffness and less flexibility. So this is what osteoarthritis is. And this is a knee joint. So you see here, this is a normal knee joint, has a good joint space between the bones. This is an arthritic knee affected by osteoarthritis, where basically the bones, as you see, become much closer to each other. This is likely a standing X-ray. So the bones become much closer to each other. You develop what we call some bone spurs, and bone spurs are usually a reaction of the bone to the irritation. So it grows an extra bone that we call it a bone spur. So this is what osteoarthritis is. And again, it's the most common form of arthritis. But today we're going to talk more about rheumatoid arthritis. So this is the autoimmune form, or one of the autoimmune arthritis, one of the most common autoimmune arthritis. And so how rheumatoid arthritis is different is that it's not a wear and tear process. It's not because the cartilage is wearing down, the joints are getting painful. It's more because the immune system is actually coming into the joint and causing inflammation. So as you said, it's when the immune system recognizes the joint as foreign. And so the immune system will attack the joint, causes pain, stiffness, swelling, and many other things happen at the same time when you have rheumatoid arthritis because of the inflammation. There is fatigue, there is sleep problems, there could be sometimes some organ damage. So this is a joint that's affected by rheumatoid arthritis. If you see here on the left-hand side, we have a healthy joint, as we discussed. We have the healthy cartilage. We have normal fluids around the joint, and the capsule and the tendons look intact and in good shape. Now, on the other hand side, you see if the joint would be affected by rheumatoid arthritis. This is an arthritic joint affected by rheumatoid. So what happens that the immune system identifies some of the joint capsule protein as foreign or as harmful. And so it brings all the immune cells and the inflammation cells into the area. This usually brings with it fluid. And what happens that this causes a lot of swelling in the joint, but at the same time, because the immune cells cause inflammation, this inflammation actually causes erosions in the bone or like destruction in the bone and in the cartilage as well. And sometimes even it can affect the tendons and cause tendon tears. So this is, again, how rheumatoid arthritis affects the joints. This is another example of rheumatoid arthritis affected joint. So we see the same, how you have some erosions in the bones that are usually characteristic. Certain erosions are characteristic of rheumatoid arthritis. You have less normal fluid and more inflammatory fluid in the joint that's affecting it and more swelling. And all of these factors lead to pain, to decreased function, and to stiffness. One thing I want you to remember, though, that Rheumatoid arthritis is mainly affects the joints and mostly affects the joints, but it is, like with many other autoimmune diseases, it is actually a systemic disease. So when you have rheumatoid arthritis, the immune system is overactive, is causing joint inflammation and joint damage. But at the same time, uh, because the immune system is throughout our body, the inflammation is actually systemic, is not only in the joints. And this leads to increased risk of many other things like heart disease or high blood pressure or diabetes. Increased risk of, increases fatigue. Usually people feel tired. Even can increase the risk of depression. And it can, the immune system, because it's active, actually can lead to other things like skin problems or lung inflammation or eye inflammation, among many other things that can happen. So rheumatoid arthritis is a systemic disease, doesn't only affect the joint. The risk factors are many in rheumatoid arthritis, and actually we still do not know how exactly. There are still a lot of studies, a lot of theories about rheumatoid arthritis, and we have a very good idea about how does it develop, but we still not 100% understanding of all the factors that play a role in developing rheumatoid arthritis. But we know that there is a genetic component, so there are certain genes that play a role, and most people who develop rheumatoid arthritis, they would have some genetic predisposition that actually would basically allow the immune system to malfunction and cause autoimmunity or the inflammation in the body. But genetics alone are usually not enough. There is always some environmental factors that would trigger the immune system to cause this inflammation. And the most commonly known are smoking. So smoking, we know it's definitely a definite risk factor of developing rheumatoid arthritis. We know that having chronic gum disease also can cause rheumatoid arthritis. The idea is that this chronic infection can actually, chronic activation in the immune system in the gums can actually produce certain proteins that can activate the immune system and lead to rheumatoid arthritis. Many other things like occupational at work, occupational exposure, stress, obesity, viral infections, all of these things can also lead to the development of rheumatoid arthritis. Obviously not alone, this leads to the development of rheumatoid arthritis in people who are already predisposed to having it, and most likely because of genetic predisposition. And one more thing that's actually, there's a lot of interest right now in studying is the microbiome. The microbiome is the normal flora that we have in our gut that is actually supposed to help the immune system function better. It helps with digestion, it helps with our bodily functions, and also it helps with regulating the immune system. So there is a lot of interest in studying this because this is considered the first line of defense, and the immune system in the gut is always active, always dealing with foreign things, with food, with bacteria. And there are many theories that when this microbiome is disrupted, meaning that there is more harmful bacteria or the balance of the bacteria is disturbed, this actually activates the immune system in a wrong way and affects the immune system and can lead to autoimmune diseases. It's not fully understood yet. It's not clear what to do about it yet. Many things have been tried to treat rheumatoid arthritis, including antibiotics and probiotics and so on, and we still do not have success with that. But this is one area that could actually make a big difference in the treatment of rheumatoid arthritis in the future, altering the microbiome. So let's talk about diagnosing rheumatoid arthritis. How do we, how do you know that someone has rheumatoid arthritis? So there are many factors, many things that we take into consideration. And if they add up, usually someone would get a diagnosis of rheumatoid arthritis. So first, the type of pain. Most people with rheumatoid arthritis would have some swelling in their joints. They complain usually of much more pain in the morning, much more stiffness in the morning. The pain could wake them up at night, early in the morning at 4 or 5 a.m. And usually the morning stiffness lasts for a long time. someone would wake up in the morning for like both hands are stiff for an hour or two, and usually it's both sides, so both hands, both knees, both feet are affected. Other symptoms like fatigue, sometimes low-grade fever could be also symptoms of rheumatoid arthritis. Yeah. On exam, there are many clues for rheumatoid arthritis. We could see that someone has swelling in their hand joints. We see that both sides are affected the same. We see that there are what we call rheumatoid nodules. So these are indications that someone has rheumatoid arthritis. In addition to that, we have many indications in the blood. So we have 3 markers right now: the rheumatoid factor, the CCP, and the 14-3-3 eta. So these are 3 markers in the blood that are specific for rheumatoid arthritis. So if someone has them, along with having the type of joint pain that indicates inflammation, usually they have rheumatoid arthritis. Inflammation markers, the SID rate and CRP, we call it ESR and CRP. These are inflammation markers that are, if they are elevated, they also indicate inflammation, so more supportive of rheumatoid arthritis. Now, if someone has joint pain that is not exactly typical, but could be suggestive of rheumatoid, but on exam, we don't find anything. The blood work looks good. There is nothing, no inflammation, no rheumatoid marker, but we still want to rule out rheumatoid arthritis because there is suspicion of rheumatoid. Imaging could be very helpful. So usually we get X-rays. X-rays, they might show bony erosions, as we saw before, that actually that could lead to the diagnosis of rheumatoid arthritis. If the X-rays are normal, we actually might get an MRI. Let's say an MRI of the hand, because the MRI is something that would show the soft tissues. It would show the exact structure of the joint. So if there is any increased inflammation inside the joint, increased fluid inside the joint, or even any small damage to the joint, the MRI would be able to detect it, and sometimes can actually help us in diagnosing rheumatoid arthritis. So this is, it's usually a combination. So the type of joint pain alone is not enough. The blood work alone is not enough. The exam alone is not enough. It's more, we add everything together to reach the diagnosis of rheumatoid arthritis. And I want to remember that having the positive blood work is not enough usually. So someone might have a positive rheumatoid factor or positive CCP antibody, but if they are not the right symptoms, if they do not have the symptoms, usually it is either they're normal or false positive, but it doesn't indicate the diagnosis of rheumatoid arthritis. And let's talk a little bit about treatment. So managing rheumatoid arthritis, there are, we have to do 2 things at the same time. So almost everyone with rheumatoid arthritis needs to be on medications, mainly because we treat for 2 reasons. Rheumatoid arthritis needs to be treated to help control the symptoms and to help decrease the pain, but also we treat because we want to protect the joints from damage. We know that from all the studies that were done on rheumatoid arthritis that early treatment usually leads to less joint damage over time. And it also helps prevent other things that rheumatoid arthritis can lead to, like lung inflammation or like increase of risk of heart attacks also. So that's why it is, if someone has rheumatoid arthritis, it is important to be on treatment. It's not only about tolerating the pain, because even if someone is able to tolerate the pain, if there is this chronic inflammation, it's going to cause damage to the body and to the joints. So it's, it's always clear from, all the studies that have been done on rheumatoid arthritis that being on therapy is actually much more beneficial long-term than choosing not to be on therapy. And we're going to talk about 2 different ways of treating rheumatoid arthritis. Medications, which I would say almost everyone has to be on some type of medication for rheumatoid arthritis, again, to control symptoms and to prevent joint damage. But also we'll talk about some other alternative therapies that we could consider, that we don't usually use them alone, but they should be considered in the treatment for rheumatoid arthritis to help. Medication-wise, we have medications that only treat the symptoms, and these we don't actually use often. So what we call NSAIDs, like Aleve, Advil, naproxen, Motrin, Celebrex, all these medications. So these do decrease joint pain, decrease joint stiffness, improve the function. The problem, they have many potential side effects if you use them on a regular basis, and they actually do not protect the joints and the body from the inflammation itself. They do not prevent damage, and that's why these are mainly for symptom relief, maybe for a short period, but not as the main therapy for rheumatoid arthritis. Prednisone is steroids, great treatment for a short period, but we don't really like using a lot of prednisone. It has a lot of side effects. Almost everyone who takes a higher dose of prednisone for a long time would get some side effects from it. So that's why we usually reserve prednisone for bad flare-ups. We can use it for a short period of time because it does work quickly and well. Some people really might benefit from a very low dose of prednisone for a certain period of time. That is okay, but it's always better to try to avoid prednisone, especially that it does not really also protect from joint damage. It mainly helps decrease the symptoms. Now, the more specific therapies that we have are what we call the disease-modifying agents. The reason we call them disease-modifying agents is because they do modify the immune system, and by modifying the immune system, they modify the course of the disease, they prevent damage, they decrease symptoms, they improve long-term results with rheumatoid arthritis. So we have oral medications. The most common we use are methotrexate, Areva, or leflunomide, Plaquenil or hydroxychloroquine, famous medication now, and sulfasalazine. So these medications are older, especially methotrexate has been used since 1980s, hydroxychloroquine since the 1950s actually. And these are good medications. They are effective. We use them usually as a first line, especially methotrexate for most people. The problem with them, they have a little bit more side effects. These oral medications, like GI side effects, nausea, abdominal pain, fatigue, they need to be monitored with blood work more frequently. But otherwise, they're effective. And many times we do actually use them for people with severe rheumatoid arthritis in combination with the biologic agents. And the biologics are the more advanced therapies for rheumatoid arthritis. These are the therapies that target a very specific parts of the immune system, and we started developing them since the late 1990s, and since then, actually, there was a revolution in the treatment for rheumatoid arthritis. Before that, there was not many good options for people who fail, let's say, methotrexate or so, but now we have many very good therapies. So the biologics, you might have heard about them, Enerbil, Humira, Remicade, Actemra, Orencia, rituximab. All of these are very effective, good treatments that treat rheumatoid arthritis. So usually we have a stepwise approach. Not everyone with rheumatoid arthritis is a very individual disease. Everyone has their own rheumatoid arthritis, how severe it is, what's their preference for treatment, what's their goals for treatment as well. So all of these actually play a kind of a big role on how do we decide on a treatment, who should be on methotrexate versus hydroxychloroquine, who should be on a biologic, who should be on a combination therapy, like using methotrexate in addition to Humira, or methotrexate in addition to another biologic. So it's really different, depends on the type of rheumatoid, the severity of rheumatoid, and the person itself, and what do they prefer, what are their goals for treatment usually. The other things that are very important, and maybe they're not usually, unfortunately, addressed as much as they should, are all the lifestyle and alternative things that we could do, or the complementary things that we could do to actually treat rheumatoid arthritis that are that could be very effective in treating short and long-term rheumatoid arthritis complications. And so we first thing, we'll talk about physical therapy and exercise. You don't have to do physical therapy specifically, but for some people with advanced rheumatoid arthritis, we do like physical therapy because it does, there is some guidance on basically what kind of exercises are safe, what kind of exercises are good to do for the long term. And usually physical therapy doesn't have to be done forever, but for a certain period of time to learn and understand what are the best exercises to do for certain people with advanced rheumatoid. But in general, exercise is actually both safe and beneficial in patients with rheumatoid arthritis. So I usually exercise would keep the joints healthy, keep the joints more flexible. It actually can increase even the joint, can increase the health of the joint and the cartilage. And also it keeps the muscles stronger. When the muscles are stronger, it does prevent weakness, but also it can protect the joints, protect the joints from further damage. So exercise is safe, and usually I'd like my patients to combine some endurance exercise, let's say like walking or cycling or swimming, with some strength exercise, like doing some weight exercises, maybe with some light weights a few times a week, or going to the gym or so. And also in addition with some range of motion and stretching exercises. So these exercises should be done on a regular basis. They have many, many benefits in rheumatoid arthritis. The benefits would be improving the joint health, improving the muscle strength. They actually could also improve sleep. They can improve the mood and have some psychological benefits. They could improve digestion. So this is why exercise is important for everyone who has rheumatoid arthritis. The key is to do it safe, do a controlled exercise, and if an exercise is triggering pain, then maybe it should not be done, or you should basically consult a therapist or the doctor just to make sure you're not causing any joint damage. The other thing that we talk about is diet. So, diet, so far there are many theories, there are many things in Google about diet and rheumatoid arthritis and anti-inflammatory diet, and unfortunately nothing is proven so far. So with all the studies that have been done so far, there is no evidence that food sensitivity or food intolerance actually can worsen RA or can cause RA. But in general, or however, like if someone notices that certain foods cause more inflammation or cause more joint pain, then it's not a bad idea to avoid it. Not a bad idea to eliminate that food in general. But so far, elimination diets that are available or advised are really not clear. There is no clear evidence about them. Honestly, they're very hard to follow, and we don't know really that they help. But my approach usually to diet is just to keep it simple, is to eat a healthy, balanced diet that is focused more on simple food and less processed food, and add things that we know can improve the immune system and decrease inflammation. So adding omega-3 is important. So I usually like my patients to be on fish oil, unless there is a contraindication for that, certain blood thinners or certain heart problems, you might not want to take fish oil. But in general, fish oil is a good supplement that has a lot of omega-3, can decrease inflammation. Flaxseed, chia, walnut, these are things that have a good amount of omega-3 that also can decrease inflammation. So usually, as a principle, you could also try to look this up and see what are what are the foods that has omega-3. As a principle, we want to make a balance that we have more omega-3 in our food and less omega-6. And if we do that, there is less inflammation usually. The other thing is adding more fiber. And so I usually actually prefer, to my patients to add fiber to every meal. So fiber is actually easy to add if you try to look what are the foods that has a significant amount of fiber. And it could be many things. It could be apples, it could be green beans, could be peas, could be cucumber, avocado, almonds, oatmeal. All of these things have a lot of fiber, and they are easy to add to the diet. So fiber can improve digestion, can decrease the risk of diabetes, decrease calorie absorption, and so help with weight loss. And yeah, so in general, again, diet, my approach is like it should be a healthy, balanced diet, more on simple foods. And as a principle, whatever is actually good for the heart is usually good for the joints and for rheumatoid arthritis. So that's for diet. Weight loss is important. We know that overweight and obesity can actually lead to development of rheumatoid arthritis, can lead to more problems if someone has rheumatoid arthritis. So weight loss is important. Supplements, there are many supplements that are suggested. The main ones that we suggest that might help are fish oil. This could be, as we said, helpful. Vitamin D, we don't know for sure. It's a little bit like not clear if it actually can help rheumatoid arthritis, but because it's a very good supplement in general for the bones, and because it could be important for the function of the immune system, and because most of us are deficient in vitamin D because we just cannot get the sun exposure that we need, or maybe we shouldn't. It's good to take the vitamin D supplement every day, usually between 1,000 to 2,000 units every day on a daily basis. Turmeric or ginger could be supplements that can decrease inflammation, and so these could be added as well. One other thing that's important to remember that we want to control all the other things that can lead to chronic disease. Like we want to control hypertension, we want to control the high cholesterol, we want to, if there is diabetes, we want to control that, because we want to control everything that, all these factors that actually can lead to increased heart disease or increased kidney disease, or even increased stroke or dementia or so. So these are very, someone has rheumatoid arthritis, very important to have an ideal control of all of these factors. Quitting smoking, obviously we know that smoking can cause rheumatoid arthritis or can trigger it. So quitting smoking both help decrease the risk of joint problems, but also can help decrease the effect of the immune system on the body, like decrease the risk of heart disease or lung disease. Dental hygiene is important. So doing regular dental cleaning to make sure there is no chronic gum disease is also helpful. We want our patients with rheumatoid arthritis to take their vaccines, because we know that usually with autoimmune diseases, there is an increased risk of infection. Rheumatoid arthritis is, the same applies here. So there is an increased risk of infection in general. And because most of the medications that we use for rheumatoid are actually immunosuppressant, there is a certain increased risk of infection, some infections. So that's why it's good to be up to date with the vaccines, especially the most common vaccine that we do need to be up to date with, like the pneumonia vaccine, the shingles vaccine, the flu vaccine, the COVID vaccine currently. Another thing that we do is we do screen and treat osteoporosis in certain people who are at high risk of osteoporosis, because rheumatoid arthritis itself and the treatment for rheumatoid arthritis can also increase the risk of osteoporosis. So it's important to be treated if it exists, or if there is a high risk for a fracture. I think that's everything I wanted to talk about rheumatoid arthritis. Maybe I could take some questions if there's any questions, so we could discuss more. Thank you very much.
Thank you, Dr. Raslan. Yes, we'll see if there are. Okay, here's one question. After 10 years of rheumatoid arthritis, I noticed more hair loss. Could that be the autoimmune disease or the medication?
Yeah, that's a good question, because it actually could be both. So rheumatoid arthritis can sometimes cause hair loss, although not common, but usually if it's not well controlled, or if there is chronic inflammation, this chronic stress on the body can actually lead to rheumatoid arthritis. Now, it depends on the hair loss. Obviously, hair loss could be a different autoimmune disease, because if someone has rheumatoid arthritis, there is a chance that other autoimmune diseases can happen. There's overlap between them. So it could be another autoimmune disease. Many times we see hair loss with medication. So there are certain medications that can lead to hair loss, most commonly methotrexate or Areva, even sometimes hydroxychloroquine can lead to that. So it, it could be the disease itself. I would say more commonly it's the medications that we treat the disease with.
How long can you be on methotrexate?
Yeah, that's another great question, because so there is no certain amount of years that you're supposed to be on methotrexate and then you stop after that. We actually, you can't. There are certain people or patients who stay on methotrexate for life. So methotrexate overall, the main risk that people worry about is liver disease. It can, in some cases, with prolonged use for 5 or 10 or 20 years, can lead to liver disease or liver cirrhosis. But that's not common, especially if we do well monitoring. So what I usually like to do is, because usually if you have rheumatoid arthritis, we actually do have to stay on treatment either for life or for many, many years until it goes into remission. The best thing to do is, if someone is on methotrexate, is to do monitoring. Even if someone has been taking methotrexate for 10 years and everything has been stable, it's always a good idea to monitor the liver function every 3 to 4 months, just to make sure if there's any change at some point, the medication could be stopped so that it can prevent any damage. I'd say methotrexate, you could stay on it for life or for 10 or 20 years, there's no problem, as long as there is good monitoring of liver function to make sure it's not changing.
Okay, do you find RA is linked to other autoimmune diseases such as hypothyroidism and celiac?
Yes, so there is an overlap between these autoimmune diseases. So there is no link between rheumatoid arthritis, Hashimoto's, and celiac disease, but we do see them frequently together. Now, it's more common that people who have celiac disease have Hashimoto's, and these two have some common genetic background that can cause them. The genes for rheumatoid arthritis and other and celiac and Hashimoto's are different, and so we could see them together. We don't know all the genes that could affect these autoimmune diseases, so there is no direct link between them, but they could happen together just because there's sometimes, if you have a genetic predisposition for one autoimmune disorder, you could have it for others as well.
Sorry. Is joint swelling a given outcome with RA, or is it controlled with the medication regime?
Joint swelling is, I would say, most people with rheumatoid arthritis have joint swelling. Some people actually don't. Once you are on treatment, there should not be any joint swelling anymore. So joint swelling is one of the markers that we see on exam, or you might notice yourself. It's one marker that there is active inflammation. If there's joint swelling, usually there is active inflammation going on. So if there's joint swelling, usually it should respond to treatment, and our goal is that there is no joint swelling on exam, like all the swollen joints are in remission. So yes, I would say most people, maybe about 75% of people with rheumatoid have joint swelling, but almost everyone, if they respond to treatment, the joint swelling improves, and there could be still some pain. Like not everyone responds 100% to the pain doesn't always respond 100%, but at least the swelling should respond.
Okay, what about new medications, Xeljanz and Rinvoq? Am I saying that correctly?
Yes, you are. Yeah, thank you. Yeah, so Xeljanz and Rinvoq, these are two newer oral medications. We have been using them, I would say, for now maybe a few years, and Xeljanz is a little bit older. Rinvoq is a newer medication. So these are what we call JAK inhibitors. So these are not exactly biologics, but they work very similar to biologics, but as like um, it's not called biologics. It's like they call synthetic DMARDs. So these medications are actually great. They're very effective. There is even some studies comparing, let's say, Rinvoq to Humira that shows that Rinvoq works better for some people with rheumatoid arthritis. So these are good options for a few reasons. They're very effective. They're very easy to use because they're usually taking as a pill once a day. The problem with them, they have a little bit more side effects. So they are stronger immunosuppressants, so there is more increased risk of certain infections like shingles. There is a new FDA warning, actually, if you look at like Xeljanz or Rinvoq right now, there's a black box warning. There's an increased risk of cardiac events like heart disease or blood clots. And so that's why these medications are good medications, very good for medications for rheumatoid arthritis. And these side effects I'm talking about are actually rare. But because of these, at this point, we're not using them as a first line. So if someone has rheumatoid arthritis, because of there are many other options available that could potentially be safer, like again, like Humira or Enbrel or methotrexate also. We're not starting with Rinvoq or Xeljanz, but we do use these medications for people who fail certain treatments and they need some advanced therapy to control their disease. And again, we should not be afraid of side effects of these medications, but just because there are potential rare side effects that could happen, especially the heart disease, we don't use them as a first line. We say them if someone fails the more traditional therapy.
Okay, what's the difference between rheumatoid and osteoarthritis, and can you have both conditions?
Yes, great question. So yes, because osteoarthritis is the most common form of arthritis, yes, you could have both conditions, or I would say most people actually have both conditions because most people have osteoarthritis and then you also could develop rheumatoid arthritis as well. So osteoarthritis there is a big difference. So osteoarthritis is not an autoimmune disease, meaning that the immune system is not causing any damage to the joint, but rather there is a chronic wear down in the cartilage of the joint. And let's say the knee joint, right? There is a cartilage between the bones, between the femur bone and the tibia. And this cartilage usually protects the bones and provides a cushion and provides some amount of fluid in the joint that allow the joint to be flexible and moving without pain. When the cartilage wears down slowly over time as we maybe get older, this is what osteoarthritis is. The cartilage wears down, the bone becomes exposed, and this is what we call osteoarthritis. So it is not an autoimmune process, but rather we call it wear and tear. Wrong, it's not exactly wear and tear, it's more than that, but it's a wear down of the cartilage for many reasons. The more we use it as we get older, some injuries to the cartilage, to the joint over time can lead to this. Rheumatoid arthritis obviously is as we talked about, is a different process. It's not a wear in the cartilage, it's more like an active process of the immune system attacking the joint and causing inflammation in the joint, and that's how the joint gets damaged, gets swollen, and gets painful.
This is a question about long-term use of hydroxychloroquine and vision. And should they be more concerned about their eyes and potential loss of sight, even though they get their eyes checked twice a year?
Yeah. So that's that's definitely a concern with hydroxychloroquine. But the good thing about hydroxychloroquine that it's a very safe medication. So this concern, it's a concern that we have it with everyone who starts hydroxychloroquine, but it's a very rare thing to happen. Obviously, we take it seriously because it can affect the vision, but this is a very rare side effect. So you're right, to ask that, because the longer you stay on hydroxychloroquine, the more likelihood that this will happen. The risk, I would say, is like maybe about 2 to 3% after about 7 to 8 years of use, and increases just a little bit over time. Most, I would say, it's a rare risk to start with, And most of the time, if it happens, it's reversible. Like more than 95% of the time, it's reversible. So the risk is minimal. And if medication is needed, and it's needed to control the disease and to prevent damage, then the benefit is much more, and it's better to continue with hydroxychloroquine. But I would say when we started, usually you don't need to see the eye doctor more than once a year. But if someone has been on hydroxychloroquine for more than 6 to 7 years, you should see the eye doctor twice a year, so that if there is any early damage, it could be detected and the hydroxychloroquine could be stopped. And again, most of the time, this damage would be reversible. Yeah, but so it's a very good medication. If it's working well and if it's needed, it's better to stay on it, but just monitor the eye frequently every 6 months, so that if there's any change in the retina, this could be detected early and the medication could be stopped.
Okay. Can you have joint pain after having 3 months after having surgery on a joint and throughout physical therapy?
After having, I understand that maybe this is like meaning a joint replacement surgery. So it depends. So let's see, after knee replacement, you could continue to have pain sometimes for 6 months to 1 year. The pain should be improving slowly. It shouldn't be getting worse. But some people do not really get to the normal joint function, or to get rid of the pain completely before like 6 months or even longer sometimes. So yes, that's definitely possible. But if the pain is getting worse or it's not improving after 3 months, then maybe it's worth reevaluating that with the orthopedist, getting some new imaging and see if there is any new issues or any issues with the surgery.
Okay, I think that's all of our questions for this evening. Thank you so much, Dr. Raslan.
Thank you, Liz. Thank you, everyone.
And